care and the gold standard for treating patients with glioblastoma, which is resection, chemotherapy, and radiation. So works wonders, but takes a lot of effort, lot of work, lot of multidisciplinary care, and lot of funding as well. And then we come to systematic reviews and meta-analyses. So systematic reviews and meta-analyses follow the PICO protocol. You have to have a question. You decide whether you have data enough. Is there an unresolved clinical question with multiple small studies? You can define a clear PICO and eligibility criteria. You will assess the risk of bias and heterogeneity, not just pool numbers together. You will register a protocol on Prospero, which is like a very good methodology to follow. You follow the PRISMA reporting guidelines. And if you include studies which are mostly retrospective and high bias, the meta-analysis can produce a very precise but wrong answer. This is something that you have to always be careful about. And that's why you require mentors and research professionals who are very experienced in this field to actually help you out in this scenario. That's the same for systematic reviews and meta-analyses as well. So the next important question is, who do you study and who you don't? So this is the question that I really like to work with or work around, is who can you include in your study and who do you like to exclude in your study? Is there a target population that you're working with? Like if I take patients from Mayo Clinic, Florida, it's going to be a Caucasian population of Florida, which is because it's a retirement community. We will have young patients, but mostly the patients are going to be 55, 60 years or above. Accessible population who you can realistically reach, yes, correct. And analytical samples, who ends up in your data set. And yeah, sampling frame, where can you take or recruit these patients from? If for a prospective study, you can do it from the patients, from the doctor's calendar, or you can do it from the OR log, electronic health records, registry, or plain simple looking through patient case reports. But yes, all of this, let me be very clear, should be done always under an institutional review board certified protocol, which we call an IRB protocol, because that is how you ensure that patient data is protected. Always, all patient data that you're working with should be de-identified. I cannot stress that enough. And proper patient consent for a case report, case series, these are all things that we need to take into consideration and be very, very, very careful about while publishing. And that's the thing, like journals have made it a very clear and a robust strategy right now that you either report your IRB number, what institution has approved it. So that is a very good way of actually covering and keeping patient autonomy as well as patient privacy intact. So when it comes to sampling, you also need to think about, I know that retrospective studies can have a selection bias, but there is always an advantage to even doing a retrospective study is so that you can be as selective as possible also. And it does not mean that you can generalize it to the entire population, but you can then answer specific questions. So there is plus and minus to both or to all of these study criteria. And I really do like once you do get into research and once you do get into publishing papers, you realize that there is a way of actually answering these questions or being more specific and robust in your research strategy. I think we've gone through this in pretty good detail. And yes, so sample size and power. So sample size and power, I generally like to keep this or like to look at this only when I'm talking about randomized clinical trials or pragmatic clinical trials or non-randomized trials. Because for a retrospective cohort study, you have to work with the patient sample that you have. Generally, if it's above 100 or 150 or 200, that's incredible. But it might not always be possible, but you still have to try your absolute best. And once you do get into the nitty-gritty of it, you then do realize that yes, why you need a sample size where in a smaller sample, suppose the effect or the result of the outcome that you wanted is not visible, but a larger sample might be able to give you that result or effect or outcome that you're looking for. So that is the reason why sample size is very important. And also prospective controlled trials which are not randomized also do benefit or do like a pilot study which actually helps you find out if the differences are visible even in a small population. It's not always necessary that if a difference is visible in a small population, it might translate to a larger cohort which has got thousands of 10,000 patients. But that's the reason why sample size calculations are important. It helps you reduce the type 1 error, which is a false positive or a false negative error, and also it helps you improve the power of your study and the thing that you're trying to establish with this study or with this project. So yeah, data collection is another thing that I really do like. There are various ways that you can get data from. Electronic health records are where you manually go through each and every patient data set and put them into like an Excel sheet in, ones or zeros, depending upon what you like. But that's what I like to do is like, if suppose a male and female is a limited outcome, you then put it as 1 or 0, as females being 1, males being 0. It depends upon how you structure your data and you become good at data collection as to how your results will also look. Like obesity, for example. It's easy to make obesity a number, a numerical value from 0 to 100. It can't be 100, but yes, it can be infinite as possible. So it then becomes a continuous variable. But if you were to then categorize it into obese, non-obese, and morbidly obese, that makes it 3 different groups, which makes it sometimes easier to study certain effects that might not be visible if you use BMI as the entire number. See, like for example, someone has a BMI of 40 kg per meter square, but everybody who in my cohort of 100 patients who had a BMI of say 35 kg per meter square and above is included in the morbid obesity. And this is me just giving you an arbitrary example, is included in that obesity criteria or morbid obesity criteria. Then what ends up happening is that I could have 75 patients, which is like a very big part or chunk of 100 patients, which get included within that morbid obesity criteria. And that might actually be able to show that patients from BMI of 35 to BMI of 40 all have the predicted outcome if it does end up to be significant with the outcome or the question that I want to answer. And that did happen with one of my other projects that I was working on, that obesity does actually affect the amount of post-operative pain medications that patients require after they have undergone a surgery. And it did actually even come as significant on multivariable regression, which is something that is interesting and something that people can look out for. So let's then go into bias versus random error. Random error is like scattered shots, like you're getting good data, but it might be a little too distributed. Whereas bias is that shots which are consistently in that same area, but they are off the center. So you've created a little bit of like, it's not that you have made any mistake, but the mistake is within the methodology or somewhere in the research protocol. And that is also very similar to accuracy. And there is a way, and there is always, like, after answering somewhere close to 40 or 50 reviewer comments, you do get to know what the reviewer likes to hear, what the reviewer wants to know, And what is there a good way to actually respond to the reviewer about this bias so that you can actually put your point forward and also defend your own research. Selection bias is one thing that I work with a lot, is because every retrospective study has got some kind of selection bias. Information bias is when you have recall bias. Like if you are collecting data about a patient who is going to go into surgery tomorrow, and you ask her, can you tell me how many pain meds, or you ask him how many pain medications you have been on, and they say, I don't remember exactly, I think it is 6, I think it is 5. That becomes recall bias because they can't tell you certainly until unless they have like a medical log where they tell, where they determine that yes, today I took 3 pills, tomorrow I'm going to have 1 pill. Oh, but the pain was too severe, so I took 2 extra pills today, so today also I had 3 pills. So that would be a very common example of a recall bias. Misclassification, differential imaging frequency, observer bias, and then third variable is confounding, because confounding is a very weird thing that can happen in research, and it is confounded by, like, if there is if there is a surgery that needs to be done for a specific pathological procedure, that can act like a confounder because almost all of your patients are going to have that pathological finding. So yeah, how do you get or reduce bias? Randomization is the gold standard way, but it's not always possible. Like in a retrospective cohort, it becomes very difficult to randomize because you already know what you're working with. Blinding is another one, but as I mentioned, and this is like a neurosurgery research group. So doing a neurosurgical research group, doing a neurosurgical study where the surgery procedure is blinded is very difficult because not every member of the team can be blinded to the treatment that they're getting. But there is a workaround. Like if you're trying to look at 2 different types of catheters or stents that could be used for endovascular procedures, you can randomize them and say that yes, care is going to be similar, pre-op, post-op, everything is going to be the same. The only difference is we won't tell you, and even the surgeon does not know what stent they are working with. Is it a drug-eluting or a non-drug-eluting stent? So that would be the way, but that's again being very minute, very specific with your research question. Restriction or narrowing eligibility or matching is something that also does help you reduce bias. It can be propensity score or one-on-one match also. And consecutive enrollment also is something that can help you reduce bias. So yeah, if you were to go through, this is one of the papers that we did get published, and it looks at post-operative opioid use in patients who underwent surgery at our institute. So the main methodology that we started what question we wanted to answer was that, do patients who undergo transforaminal lumbar interbody fusion under one surgeon who performed the procedure at the same hospital in all consecutive patients that had undergone this procedure under him? And what we wanted to check is, are outcomes or the post-operative opioid usage or pain medication usage higher in the patients that underwent the procedure under general anesthesia versus the patients that underwent the same procedure with the same surgeon, with the same care team, with the same operative times, with the same procedure logs, in comparison to spinal anesthesia or awake spine surgery, which is something that I am also very interested in studying. So, as I told you, we started with lumbar spine procedures that were performed by a single senior spine surgeon at a tertiary care institute. And this is how you keep everything anonymous so that journals don't have a bias as to whom they're going to select for their publication as compared to whom they're not going to. And we included all consecutive cases. And these are all spine procedures that were performed by this surgeon. 420 is an incredible number for a tertiary care institute. which does not do emergency surgery. Out of these, we just wanted to focus again. T-lifts can be done for 3 levels, 2 levels, 1 levels, but we wanted to do only 1 and 2 level. Now, the reason why we wanted to do only 1 and 2 level is a 3-level T-lift can also be done for spinal deformity. And at what level or in what cases it becomes for a spinal deformity or for like spondylolisthesis is very, very specific. And we wanted to actually bypass that bias that would be created, because deformity corrections can be painful. And we knew that we would get a lot of pushback if even 3-level T-lifts were used. So that's why we wanted to keep it to 1 and 2 level MIS T-lifts. But this is not something that I did. Like, this was my mentor and PI who had the clinical skills and the brilliant knowledge to actually, or the insight to actually tell us that this is how we would, counteract this, or this is why I don't want to do 3-level T-lifts. So out of those 192 patients, we had 121 that underwent surgery under general anesthesia and 71 that underwent surgery under spinal anesthesia. Now, the brilliant part about this was, up till this point, we had not done any data collection of demographics, about age, about, diagnosis, yes, we had done collection about. The reason was, I didn't want to do data collection, and this is how you should think about your research projects. I didn't want to do data collection on 420 patients and then decide what my question was, or then decide what I was going to look for. And to be very honest with you, because we did not want to use chronic opioid users, the reason why we didn't want to use chronic opioid users also has a very good and published data showing that patients who take chronic opioids prior to surgery have a high likelihood of having post-operative or increased post-operative opioid usage. That's the reason why we excluded 40 patients from this general anesthesia group and 14 patients from the spinal anesthesia group that were taking chronic opioids, so that we would have as homogeneous cohort across both the surgery, both the anesthesia types. But also at the same time, what this would help us do is that it does maintain the homogeneity. But the only difference, like that is what we were trying to do. The only difference we wanted to see, or we wanted to keep the cohorts only different on that one aspect, that is spinal anesthesia for TLIF versus general anesthesia for TLIF. And to even reduce the confounding further, we then did a propensity score match between both groups. And this propensity score match is done on age, risk factors, preoperative symptoms. That's the part where for the 57 plus 81, that is somewhere close to almost 138 patients that we did full data extraction and collection for, post-operative opioids, post-operative prescriptions given. And then we ended up with 50 patients in each group. And that's when we did analysis. And, we were able to show that there is some, there is a way of actually showing that spinal anesthesia had reduced post-operative opioid needs in comparison to patients who underwent a procedure under general anesthesia. But this is just a suggestion. That's the other thing. Like, this is only in our retrospective cohort. This is only with our surgeon that we were able to see this. Reproducibility depends upon if you follow the same procedure, if you do it with the same care team, if you use the same spinal anesthesia versus general anesthesia protocol. So, and those are things that you do have to mention, that yes, we were able to find this research, but these are also the other things that you would have to consider in the outcomes of this research. And that actually also helped us to make our own prospective study protocol, where we wanted to, when we are recruiting 45 patients into 3 different groups for the same procedure, spinal anesthesia versus general anesthesia with a spinal block for post-operative opioid use. And so this, if I were to go through it, these are our project objectives, which is very similar to what we did. These are the prospectively collected studies that we wanted to do. These are all patient-reported questionnaires. Oswestry Disability Index is something that is very easily reported. Yes. The other thing that's important is when you're designing something, you should take, initially at least, you should stick to metrics that surgeons, reviewers, and researchers or the entire community is very easily agreeable on. Like Oswestry or ODI is very what's it called? Easily accepted. Like all surgeons do know that a neck disability index or an Oswestry disability index is a very commonly reported metric. It's not something that is new, not tested, not reported, or not published. This is just a little more of the stuff that we did for our research protocol. This is the actual protocol that I run because I do actually work as the clinical research coordinator on this also. The recruitment strategy that we spoke about. So yeah, like based on that paper that we had, these are the pitfalls that we actually had to be very careful for while we were structuring this. And this IRB also, to get it approved, is a long process, like 6 months to 8 months. But that's it. Like you have to keep at it, constantly, trying to make your research better, the research question better, and at the same time seeing to it that it's all within a very good and ethical structure. So we did do an extra part also where we looked at inflammatory markers, and I did the blood extraction for the patients. But yeah, that's about it. If there are any questions, please do let me know. Thank you so much.
Thank you so much. Thank you so much, Dr. Iyer. Your lecture was absolutely fantastic, and we got a very practical overview of how we can transform these clinical questions and translate them into actual research projects. I'll be handing this over to Marwan, please, to continue our discussion.
Thank you, Isha. And yeah, as she said, thank you, Dr. Iyer, for this amazing lecture. I really appreciate it, and I really liked it. You explained everything very smoothly. So yeah, if anyone has any questions, I think, Aisha, you have your hands raised, so please go ahead.
Thank you so much, Dr. Iyer. It was a very insightful lecture. I have a question about what do you mean by patient match score? Like, how does that work when you're designing a study? Can you explain it a little bit more?
You mean propensity matching or?
Yes.
Okay. So propensity matching is also something that one of my statisticians did for me or helped me with. So propensity match is not actually a one-on-one match. Like say, suppose you have one patient A and patient B. Both are 80 years old, both are female, both are having 6 comorbidities, same comorbidities. Both are taking the same medications for those comorbidities. Both have had those comorbidities for the same amount of time. But finding this is like finding a unicorn, if you understand. Like, and it's easy to do this when I'm going to enroll a patient prospectively. Like if I have myself as a patient, it's very easy for me to find another patient who doesn't have the disease but might have the same risk factors and everything else in comparison to me. Now what happens is that in a retrospective study, all my patients have already undergone surgery. They have already had their outcomes. They've already had their 1-year follow-up. But there is good data there. I just don't want to dismiss it because this patient was 76 years old and this patient was 74 years old. So what propensity score does essentially is it gives each and every one of these patients a significant score, like a 0.83 or a 0.87. And then you match on the basis of that score. So it's not a one-on-one match exactly. It matches the score, like a 0.83 with a 0.83.
Okay, so is there like any limit to it? Like we only include like 0.3 and we don't include 0.8.
That is exactly, that is your decision. How selective you want to be is whatever you decide.
Okay. Thank you so much.
Most welcome.
Thank you, Dr. Iyer. Sunusi, please go ahead.
Okay, good day, everyone. Thank you very much, sir, for such an informative lecture. Thank you very much once again, sir. So I have two questions. One, please, I want you to highlight what the exact difference between allocation, concealment, and blinding in a randomized control trial. And second, as a somebody from Nigeria, that's a third world country, I can see. If I want to apply for research fellowship in USC, what is the requirement and how competitive is the process? Thank you very much, sir.
Oh, I think I missed your first question. I think my connection cut out. Can you please repeat the first one? Sorry.
Okay, sir. I said, please, what is the exact difference between allocation, concealment, and blinding in a randomized control trial?
Oh, so blinded randomized control trial is like the best case scenario where the patient, like it can be single blinded, double blinded, or it can also, like you can have an extra layer of protection and even have like a triple blinded study, where even the clinical research coordinator and the entire admin team doesn't know what criteria the patient is in. But true blinding, you can never have achieved, the maximum. The reason is because how do you then know if the research or the outcome worked if it's completely blinded? There are ways and there are softwares who can do that also, but you still have to know that. So double blinded would be patient doesn't know and the caregiver or the treatment faculty does not know. Triple blinded would be also, yes, the admins don't know or research protocol followers don't know. And that is how you maintain a very good structure for a blinded study. And the second was, you said allocation. So allocation is like you actually do allocate these patients by yourself, but taking into consideration that you have matched the patients whom you match into your cases and your control. But it's not true random or true, So true randomization, even I don't know how the patient gets allocated because it's an algorithm that gets used. You use an actual software or you use some randomization program that randomizes these patients into it. So it could be like you have the first 5 patients that get randomized completely into your control group. It's not you deciding it. It's the software that decides it. And for your second question, I wish I could tell you that there is like a very straightforward way to get to the United States, to do a research fellowship. I would be lying. Most of it is you have to constantly keep trying. You have to constantly keep reaching out. I would say, I'm not saying that it's a necessity, but if you do have your steps done, at least step 1, it does put your hat a little higher in comparison to people who don't have their step exams done, because that is a very good criteria to show that you are very interested in doing your residency in the United States. The other criteria would also be that you do have a little bit of research experience. You don't need to be like best researcher, but yeah, if you've got 4 or 5 meta-analyses or systematic reviews, they do know that you know research methodology. Like for me, I genuinely didn't have that much experience, but I had finished both my steps, step 1 and step 2, prior to coming here. So how I played it was that I am done with both my exams. I'm just here to learn. And I came initially as an unpaid research fellow for almost 16 months. I worked in basic science as well as clinical research, and that's what I did. Like, as much as possible, get yourself involved in as much research as possible. And there is like, it does get better, but it's not easy. That's the only thing. And you have to keep trying. The other thing would be like, constantly keep trying. It's not about who gets it or who doesn't get it, and if it's fair or not fair. The only thing that it's true about is the person who keeps trying the most does eventually get through. That would be my 2 cents on the topic.
Dr. Iyer, sorry for interrupting. Thank you for the answer. But the meeting is going to end in a few minutes, so we're going to send another link. We have a technical problem. Sorry about that. So I think if there are any more questions, we can send the link so they continue with their questions. If there are any more questions, or if there is anything, Dr. Iyer, you want to add, we can send the link, and so that everyone.
That's it from my end. I would just say that thank you so much. You guys are doing such an amazing job. I would have wished to have something like this when I was starting my research journey. But whenever possible, please don't hesitate to reach out. I would also like to shout out to Mission Brain, who I do research with. We are a really good community. Many of the people here also have heard or do know about it. And yeah, keep trying. Surgery in the United States is your dream and goal. Keep at it, We're here.
We really appreciate it. We really appreciate it, Doctor, your help and your lecture here and your words. We really appreciate it. And yeah, of course, we're going to share your socials if anyone wants to contact you. And we'll hopefully stay in touch, and we can see you be a big spine surgeon, hopefully.
Oh, thank you so much.
Yes. Thank you so much.
Thank you, Doctor, and thank you everyone who joined.